try to get to them. We wanted to start off by asking Dr. Vira, during the crisis, which has interrupted a lot of our normal behaviors as residents, fellows, medical students, we were wondering if you had any advice for all these people eager to learn and improve on their urologic skills, to try and take advantage of, maybe additional downtime or additional lecture series or whatever you think.
Sure. Well, first of all, you're doing it right now. Obviously, kudos to all of you, for the organizers, for putting this together. And, it's a unique time, and that to hear from all of these docs from across the system or across the area, to give you these lectures. So, obviously it's tough for everybody. I'm sure, like most of you, we haven't really operated in the last 4 or 5 weeks, and sometimes it's hard to keep yourself motivated to keep doing something that's going to help educate yourself and so forth. But doing these lectures, I think this is a great time to really think about some of your academic research activities and trying to get some of those things in order. Obviously one of the biggest barriers to doing that well is not having enough time. And right now, some of us at least have some time. I'm sure a lot of you have been deployed and have been in various ICU and COVID units and everything else. And certainly my hat's off to all of you. Put yourselves out there and in situations you're not familiar with, and and doing the best that you can. And obviously the each health system owes a debt of gratitude to all of you. So but yeah, honestly, taking this time to do some reading, to thinking about academic work. I'm not sure how much access there is to simulators and things like that, but these are the times when you can really spend time. And one of the things that really helped me, at least certainly during my fellowship time, was the ability to kind of look at videos and really, at least for minimally invasive surgeries, to go back and critique myself and the videos that I was performing, and looking at expert videos, and really thinking about what's going on, writing down steps, taking notes and so forth, because a lot of that prep work time will help you, in the future as you're in different cases and so forth.
Excellent. Thank you so much for that. And thanks so much for being here.
Sure. All right, so I guess why don't we get started? And as you said, feel free to put some questions in the chat box. And Michael, if you want to just you can interrupt me in between if there's a question that comes up about something that's on the slide, or we can obviously answer some of those questions at the end. And again, thank you for having me, and it's a pleasure to be here talking to all of you. So today we're going to talk about just kind of a risk stratified management of non-muscle invasive bladder cancer. Kind of nuts and bolts type of thing. A lot of this is I kind of modeled off of the AUA guidelines and so forth, just to keep it structured, and obviously try to hit some high yield topics that will show up on in-service exams and board exams and so forth. Let's see. So just a little outline of the talk today. We talk a little bit about epidemiology of bladder cancer in general. Talk a little bit about the molecular pathophysiology. We'll go through some of the ins and outs of the diagnostic testing, biomarkers, and really the crux of this is really thinking about risk stratification, and I think that's the key to understanding and managing non-muscle bladder cancer in an organized and standard way. We'll talk about the treatment considerations for the various risk groups, talk a little bit about follow-up and surveillance, and then just touch a little bit on what are some of the future directions that we're going for and some of the questions that need to be answered. So this is just from the cancer statistics, cancer.gov statistics, looking at this year's cases of new bladder cancer, about 81,000. We'll expect about 18,000 bladder cancer related deaths. Obviously, the majority of these deaths are related to patients who have muscle invasive or higher stage disease. But as we'll touch on later on, certainly patients who have non-muscle invasive bladder cancer, a percentage of those patients will be at risk for progression and eventually cancer-related death. This is where bladder cancer sits on the kind of spectrum of the various cancers that are diagnosed in America. And you can see that's the 6th most common cancer diagnosed in people. And I'm struck by this slide all the time when I look at if you just add up the number of prostate cancer, bladder cancer, and kidney cancer cases as well as deaths. You know, in geo-oncology, we end up taking care of a significant portion of patients, both men and women, who will face not only a cancer diagnosis, but potentially a cancer-related death. Overall, you can see on the right here that bladder cancer represents about 5% of all new cancer cases in the United States. And we look over time in terms of what's been happening with the incidence of bladder cancer. For many years, you know, the incidence rate was pretty flat in terms of the number of new cases being diagnosed. Certainly the number of deaths have been pretty flat over the years. And then somewhere in the early 2000s, we start to see this decline in the number of cases. And this really corresponds to a decline in smoking rates, which we all know is the #1 risk factor for bladder cancer. And so, you know, we start to see a decrease in the number of patients. Now, we're not necessarily seeing the decrease in the number of deaths yet, but I would expect that this should lag behind the incident cases, and hopefully over time we'll start to see a decrease in the death rate. This is really, again, fleshing out in terms of the incidence and trends in incidence and death rates, looking at bladder cancer as compared to other cancers. And at least on the left-hand side, again, you see that bladder cancer is definitely one of the cancers that have seen a significant decline. Obviously, lung cancer being the highest number of decline over the last decade or so, and that really has to, again, to do with the decrease in the tobacco exposure to people. When we see some of that, obviously, we've seen that in prostate cancer, maybe related to screening changes, but bladder cancer as well. And the same thing on the right-hand side, we see the death rate from bladder cancer has declined ever so slightly over the last decade or so. And hopefully, again, that number will increase in terms of the decrease in number of deaths over the next decade coming. And this is just looking a little more up close to that graph. And again, you can see right at the end of around 2000, you start to see this significant decline in the number of cancer diagnoses, both in men and women. The other thing to notice on the left-hand side of the graph, you know, men made up a much higher share of overall bladder cancer as compared to what we see today, where you know, where it used to be a 3 or 4 to 1 ratio, it's now coming down to about a 2 to 1 ratio in terms of men and women with bladder cancer. So in terms of risk factors, obviously tobacco exposure is the #1 risk factor. Somewhere between 60 to 90% of all patients either have a primary or secondary exposure. Worldwide, it's thought that 50% of all bladder cancer, the attributable risk is tobacco exposure. And there's been some very large epidemiology studies that have shown, you know, obviously a huge increased risk in current smokers as well as former smokers. And, you know, one of the things that we all see is that even in patients who have a relative distant history of smoking, their risk seems to be higher than the general population. And when you contrast that with lung cancer, generally after about 10 years, the risk of lung cancer in smokers after 10 years after quitting starts to really decline. And by 20 years after smoking, the risk is almost similar to the general population, certainly a general population in an urban area. Whereas with bladder cancer and urothelial cancer in general, that risk, even if someone has quit smoking 20 years ago, seems to persist. So, you know, there's something about the underlying changes that occur in the mucosa that, you know, set the stage or set the seeds to developing bladder cancers. The other big risk factor is obviously occupational exposure. This is a graph that's actually in the current version of Campbell's or table in current Campbell's, looking at relative risks of various occupations. And again, I was struck by the fact that both nurses and physicians are on this list. And it's interesting to see, in terms of where that exposure may occur, in terms of increasing that risk. So, obviously the easy ones are the tobacco and dye workers and chimney sweeps and so forth. But there's certainly a lot of other occupations in which exposures can occur and lead to bladder cancer diagnosis. So this is a pretty old slide. It goes back almost 15 years. And really just in a very broad overview way, looking at the molecular and genetic pathophysiology of development of bladder cancer. And one of the common questions that always comes up on the SASAP questions is, the most common chromosomal abnormality or genetic abnormality seen in bladder cancer, and that's the loss of chromosome 9. And we really think that this is an early event, as we see it both in non-muscle invasive and muscle invasive bladder cancer. But the current line of thought is that there really is this dichotomy in the pathway in which you see the urothelium have some changes and either go down a pathway where we're really talking about lower grade and non-muscle invasive bladder cancer that can be recurrent, obviously, but not necessarily progressive, versus you start to see some of these other mutations in p53, RB1, that really lead to a more of an invasive phenotype. And over the years, some of these changes that come along in the progression really are starting to be fleshed out in terms of which mutations are driving progression and advancement of disease. Ultimately, obviously, when patients develop kind of metastasis, there's this epithelial mesenchymal transformation that occurs. And again, a lot of work is being done in this area, looking at some of those potential changes and obviously looking for actionable targets so that therapies can be developed. And I put up this next figure, which is from a much more recent paper in 2015. And again, I'm struck by the fact that it hasn't really changed all that much, other than identifying some of those mutations in a more standardized fashion in terms of looking at the invasive versus non-invasive phenotype. But really, even going back 20 years, the same underlying theory of kind of this dichotomous pathway still stands, and we start to see again early p53 and RB1 loss in the invasive phenotype, FGFR3 in the non-invasive phenotype. And as we understand these things, we can start to think about treatments that we can target these areas, target these potential mutations to treat these patients. And much of targeted therapy and cancer biology is really aimed at more advanced disease, metastatic patients, and so forth. But certainly, there's an opportunity as we learn more about the molecular pathophysiology that using some of these developing some of these drugs early on in therapy may help alleviate or ameliorate some of the invasive phenotype and prevent more advanced disease in these patients. This is just a figure, again, it's from the current Campbell's version, but it talks about the TCGA work, and as well as some other institutions really looking at different molecular signatures. And we start to see that there are really different subtypes of bladder cancer. And while most of this work was done in muscle invasive disease, I think that as we gain more data, we'll start to see some of these subtypes really manifesting even in the non-muscle invasive disease. And I think this will be key for us to stratify patients even further than our current stratification schemes. Perhaps identifying a subset of patients that will go on to progress to muscle invasive and advanced disease, and instituting earlier cystectomy in those patients, versus again developing therapies against some of these early mutations and other early changes, and maybe stop this process of development of muscle invasive disease. So right now we don't have this idea of a luminal versus basal subtype in non-muscle invasive disease, but I suspect that again as the data comes along and we understand this more, that we will be able to subtype these non-muscle invasive bladder cancers into different groups. So let's talk about, diagnosis and detection. Obviously, that's very important in managing bladder cancer and understanding where patients are at the time they're presenting. Cystoscopy, as you all know, is really the mainstay of diagnosis. The sensitivity of cystoscopy for lower urinary tract bladder cancer is approximately 90%. So it's very good, obviously, identifying papillary nodular tumors and even areas of carcinoma in situ. Most of the guidelines, or all of the guidelines, really recommend that all patients at the time of diagnosis during their initial evaluation have upper tract imaging by CT urogram or MR urogram, or in patients who are unable to have contrast, doing retrograde pyelograms at the time of their tumor resections. One of the changes that has occurred over the last decade or so is enhanced cystoscopy. And enhanced cystoscopy, or blue light cystoscopy, which I'm sure many of you are familiar with, is endorsed by both the AUA as well as the EAU guidelines. So, I think all of the major governing bodies have recognized the value of blue light cystoscopy and incorporated that into their recommendations during the evaluation and really treatment. So with regards to blue light cystoscopy, as you know, it involves installation of Cysview or Hexvix inside the bladder. These porphyrins are then taken up into the cancer cells, and then under blue light wavelengths, they become more obvious. Now, I don't know how many of you have actually performed cystoscopy with blue light. I wish all of the pictures really looked like this in terms of the tumors really being delineated, and there's certainly I think a learning curve in understanding what you're seeing and not overcalling some areas. They may look abnormal, but as you see in these pictures, sometimes, especially that you can see in that top picture, the real value of blue light and Cysview is that it highlights areas that may not be as visible on white light cystoscopy. Now, it's not perfect. In many of the studies, blue light alone can miss about 10% of the tumors that can be seen. But on the other hand, white light cystoscopy is thought to miss maybe up to 30% of satellite lesions. So, incorporation of this really helps not only from a diagnostic standpoint, but even from a treatment standpoint. And this is really backed up by data. So one of the early studies looking at Cysview, ultimately our outcome that we're looking for is not just, how well are we able to find it, but how well are we able to treat it. And what blue light cystoscopy does is really help identify all of the tumor tissue in the bladder, so that at the time of TURBT, you have a more complete resection of the tumors. And this translates, at least in this study, up to a 12% reduction, a 24% reduction in the 12-month recurrence rates. As I said before, that blue light cystoscopy can detect at least one additional tumor as compared to white light cystoscopy in about 30% of patients. And in one particular study, this is actually a meta-analysis of a couple of different studies, they actually did show a decrease in the progression rates. And I think this really has to do with not only identifying all the tumors, but we're potentially getting better, more complete resections of the tumors, and probably more accurately risk stratifying these patients. So, it may be that if you have an incomplete resection or you miss certain areas, that you're going to be underdiagnosing some of these patients in terms of missing CIS or some of the invasive phenotype. And so if you're able to identify those patients more accurately and then prescribe obviously better treatment for those patients in terms of BCG and maintenance therapy and so forth, that ultimately down the road has an impact on progression rates. The other area that blue light cystoscopy is used for is in terms of office cystoscopy, in terms of diagnostic and surveillance, after bladder cancer diagnosis. And real value here is more accurately defining areas that, of CIS. Identifying those patients earlier in their process before it becomes more diffuse throughout the bladder, so blue light cystoscopy can improve the diagnostic capabilities of in-office cystoscopy. Obviously, the downside of blue light cystoscopy is the logistics. Patients have to come in about an hour before, have the installation put in, wait in the office, and then have their cystoscopy. And then unfortunately, there's also a significant cost associated with the equipment. Blue light cystoscopy can't be done on any equipment. I think Storz is the only system right now that makes the tower and so forth. So, there's an upfront cost, and getting it in the hospital is one thing, but getting it in your office or multiple offices is a whole nother level of expense. So cystoscopy, obviously, number one part of the diagnosis and detection of bladder cancer. The second thing that we use is urine cytology. So that's, those two together are really probably the most broad ways that we are able to diagnose and maintain surveillance. Cytology is much better with high-grade disease and CIS, and that's really where it shows its value. The sensitivity, though, is not great, 30%, maybe even up to 40%. And the real value of cytology is specificity, is that it's very high. So, in patients who have a positive urine cytology, up to 95, 96 of those patients are going to have urothelial cancer somewhere. So, we have to go looking and doing biopsies, looking at the upper urinary tracts to find this. One of the important things about cytology is that it's somewhat user dependent, meaning that you have to understand what your pathologist or cytopathologist is looking at. And it really takes discussion and integration with the cytopathology team to understand what their parameters are. At least at our institution, we generally have 4 different results for cytology: benign, atypical, suspicious, and positive. And that's actually evolved over time as we've correlated what their results are with biopsy findings, and really to help them fine tune their reads, and more importantly also standardize their cytology reads across their department, just because you want to make sure that whether it's one or another cytopathologist that's looking at the specimens, that you're going to get a consistent result. So taken together, cystoscopy and urine cytology perform very, very well. I mean, taken together, you're talking about a greater than 90% sensitivity and specificity. So combined together as a diagnostic test for both screening as well as for surveillance, it's really excellent. Now, a lot of work has been done to look at other urinary biomarkers, with the idea that perhaps these biomarkers can detect cancer earlier, perhaps have a better sensitivity than cytology, and ultimately we'd love to be able to have a test that will help us avoid cystoscopies in some of these patients who don't need it, just to, again, reduce the amount of invasive procedures that we're doing. So we'll go through, some of these in more detail, but basically, there are certain tests that look at the proteins in the urine. Immunocyte is really meant to be as an adjunct to cytology. I'm sure many of you are familiar with UroVysion FISH, which looks at FISH for certain genetic alterations in the cells. And then there are some of these are just 3. There are actually others as well that are relatively new, most of them looking at various genetic factors or parameters within the urine. None of these have really been widely validated in practice to become part of routine use. The BTA stat, BTA track was the first test. The real benefit of this test is really that it's point of care. So, in office, you can get a result right away. And it only takes about 5 to 10 minutes. Again, this is looking at an antibody to a protein on the cell surface in the urothelial cells that are in the urine, that are shed in the urine. NMP22 is another point of care test. It was FDA approved in 2003. This is an antibody that's based, it's looking at nuclear matrix proteins in the urine. And again, the main benefit here is really the fact that it's a point of care test. So when the patients come to the office, they submit the sample, and you can wait a little while, but get the result while they're still in the office about their urine. So immunocyte, as I alluded to before, is actually FDA approved as an adjunct to cytology. And although I don't think it's widely used, it's really beneficial in patients who have perhaps atypical cytologies to isolate the urothelial cells and help the cytopathologist make a more accurate diagnosis of what they're seeing. You can see a picture on the right-hand side of the screen, and one of the things the cytopathologist looks at as a cytology specimen is clumping of the urothelial cells. And sometimes, as the cells are clumped, although they may be suspicious for cancer, it also can sometimes inhibit the or interfere with the evaluation of the nuclear material within the cells. And so immunocyte helps to isolate those urothelial cells and help the cytopathologist make a more accurate diagnosis. So UroVysion, again, is probably the most widely used of all of these urinary biomarker tests. It's a FISH-based analysis looking at chromosomal abnormalities, and there are really two parts of the test, and either one of them being abnormal will give a quote-unquote positive test for FISH. So the first part of the first test is actually looking at aneuploidy at 3 chromosomes, chromosome 3, chromosome 7, and chromosome 17. And you can see that in the picture on the right. In the specimen up here, you see really 2 copies of each chromosome. And that's obviously a normal cell versus a positive test here, where you see the green antibodies, and you see multiple copies of that chromosome, and so you see aneuploidy of those cells. The other one is the loss of the 9p locus, and we touched on before earlier that chromosome 9 loss is the most common genetic abnormality seen in bladder cancer, and so really you're looking for loss of this locus in those cancer cells. So any positive test would either have multiple cells with aneuploidy or loss of chromosome 9. The thing about UroVysion FISH is that it is urine volume dependent, so you need to have an adequate sample, so there's an adequate number of cells to be tested. Otherwise, you get a non-diagnostic result. In terms of some of these novel biomarkers that are out there, CX bladder is urine-based. It detects mRNA of 5 genes. They actually have 3 products that they have commercially available. One is called a triage, then there's a detect and a monitor, and they're all meant to be at various stages of evaluation. Triage test is really for evaluation microscopic hematuria, detect and gross hematuria monitors for patients who have a known diagnosis with bladder cancer and are on surveillance. Euromonitor, I think this was recently published, as is EpiCheck, and Euromonitor uses RT-PCR against looking for mutations in two genes. One is the promoter region of TERT, and the other one is mutation FGFR3. We talk about FGFR3 being a very common mutation seen in non-muscle invasive bladder cancer. And then finally, EpiCheck, which is a urine-based assay looking at 15 DNA methylation markers. So, all of these have been published in series and have shown some improvements in sensitivity over the standard tests. None of them really approach the specificity of urine cytology, but it's certainly the test-based characteristics are improving. These tests all need to be validated in larger series, really used more in common clinical practice before I think they'll be ready for prime time. So with those standard ones that we had talked about before, just looking at the test characteristics of each of those tests, what you can see is that all of these tests really improve on the sensitivity of cytology, somewhere between 70 and 85%. But unfortunately, none of them approach the specificity of cytology. And so you're already talking about a very high bar that these tests are trying to achieve when you compare cystoscopy with cytology, and you compare the very high sensitivity of cystoscopy and then the very high specificity of cytology. It's a very high bar for these tests to overcome. So when you start thinking about, okay, well, what are really the goals of biomarkers, and where do we stand in terms of those tests performing in bladder cancer? So first question is, can you avoid cystoscopy using these biomarkers in a screening population? So patients that are coming in with hematuria. And although some of these tests do have some indications for that particular area, right now we would say no. They really have not performed well enough to avoid cystoscopy in the screening process. What about surveillance? Can we avoid cystoscopy in bladder cancer patients with these tests? And in general, and as per not just the SUO AUA guidelines, but also in the other organization guidelines, no. So these tests are not meant to, or are not ready yet to avoid cystoscopy. And meaning, when we talk about that, what we're talking about is if you have a test that's normal, can you skip their 3-month or 6-month cystoscopy? And right now, again, those tests don't have the test characteristics to do that. What about improving detection in patients with negative or equivocal workups? So yeah, I think that there is some value in either UroVysion or Immunocyte in terms of maybe more accurately finding patients. But the cost of these tests are really high, certainly compared to cytology. So, right now, I wouldn't say it should be for routine use, but certainly something to consider. The other issue is that because their specificity of these tests is not as high as cytology, the question is, well, what happens when you have a positive test? Do you have to take those patients for biopsy? How often do you have to biopsy them, and so forth? So there's certainly some increased morbidity that's associated with false positives. And we talked about, again, the value of Immunocyte in terms of clarifying atypical or suspicious cytology. And then finally, what about identifying patients for future recurrence? And can we use some of these tests to stratify patients based on the results in terms of how often they need to be scoped going forward? So UroVysion is the one that really has data, at least to support using it as perhaps a stratification factor for patients. And this first study is recently published at Southwestern. It was actually a multituditional study. It was a prospective, non-randomized study. So about 150 patients who were in surveillance for non-muscle invasive bladder cancer. And what they did was they checked they had a UroVysion test prior to their BCG treatment. And then they checked at various time points right at the end of BCG at 3 months and 6 months and going forward. And what they found was that if your FISH test was positive at baseline, that your hazard ratio for having a recurrence post BCG was 2.6, and if your FISH was positive at 3 months, your hazard ratio was 3.2. So, this perhaps can help stratify patients in terms of how often they need to be cystoscoped going forward. And this is, again, another study published this year. There's really a meta-analysis of prior studies, included about 400 patients. And in this particular study, they did not find an association with the pre-treatment FISH test, but did find a very strong association at that 3-month test. So in patients who were post-BCG treatment and at the time of the first surveillance cystoscopy at 3 months, if your FISH test was positive, your hazard ratio for developing a future recurrence was 3.7. So and I think that there are still some ongoing studies looking at this particular question, is that can we use a FISH, UroVysion FISH, for patients who may have intermediate or higher risk disease, and stratify them and tailor their surveillance or follow-up schedule based on these results. So when we're talking about stage distribution for bladder cancer, roughly 3/4 of all patients who show up with their new diagnosis of bladder cancer will present with non-muscle invasive disease, and about 1/4 of all patients at the time of presentation will have diagnosed with muscle invasive or worse disease. So obviously this talk is really focused on those that first group of patients who present with non-muscle invasive disease, which represents about 75% of those patients. And within that, roughly 1/3 of those patients will be T1 or CIS, and 2/3 will be confined to the mucosa. So, again, as we talked about earlier, I alluded to earlier, that the key to managing non-muscle invasive bladder cancer is risk stratification. And my residents will tell you this is one of my favorite questions to ask in the operating room, in terms of, where does this patient fall in terms of risk, and then how will we manage those patients? So understanding this slide will really be the key to kind of correctly or accurately monitoring or following bladder cancer. So low risk. So these are patients who have low grade, mucosa confined or TA disease, generally solitary and less than 3 centimeters. Intermediate risk patients are patients that have either multifocal low grade, large low grade TA lesions, or kind of the isolated smaller high grade TA lesion. We always throw low grade T1, but honestly, my pathologist hasn't reported a low grade T1 probably in about 10 years. I don't think I've ever actually seen it in any of my patients. So I'm not sure this really exists in terms of low grade T1 tumors. And then early recurrences of low grade TAs, we bump their risk into intermediate risk. In terms of high risk patients, these are patients with high grade T1, patients who have recurrent high grade TA, patients who have very large or multifocal high grade TA lesions, CIS, variant histology, lymphovascular invasion, and then in the bottom here, the BCG unresponsive patients, and these are probably some of our highest risk patients. Now this particular table here, looking at the risk stratification, is from the SUO AUA guidelines, the EAU, the UK body, the NCCN. They all have their own risk stratifications, and for the most part, they're relatively similar to this. I think some of the other guidelines bump all of the high-grade patients into high risk, rather than separating the smaller versus the larger lesions. So when we talk about risk, really, what are we talking about? We're talking about risk of recurrence and risk of progression. And these are relatively rough numbers in terms of what is the risk of recurrence. And as you can see, between low risk, intermediate risk, and high risk, there's a difference in their 3- and 5-year recurrence rates. But the one down here, the second and third row, are really important ones, and that's the risk of progression. And so, patients who have low risk disease, their risk of progression and death from bladder cancer is very, very low. And these patients can be monitored, less closely than the higher risk patients. And as we'll talk about, really don't need to be aggressively treated. Versus the intermediate and high risk patients are the patients that are the higher risk for progression, which directly correlates with death from bladder cancer. So this was a paper that was just published last month, looking at just a validation of the current risk stratification that's published by the AUA. And what you can see here on the left side is the risk of recurrence. And again, over 5 years, you can see the low risk, intermediate risk, and high risk patients. We said that there was a 70 to 80% risk in the high risk patients, 50 to 70% risk in the intermediate risk patients, and less than 50% risk in the low risk patients is what we see here. And again, the more important part of this is the risk of progression. And in these high-risk patients, over time, you can see really, even going up to 5 years, the risk of progression is significant in the patients who have high-risk disease, versus in the patients who have low-risk disease, their risk of progression is extremely small. So how do we manage low-risk muscle-invasive bladder cancer? Really consider doing the intraoperative or postoperative installation. Most of the studies have shown about a 25% to 30% risk of, or decreased risk of recurrence with an immediate post-op intravesical chemotherapy. And most of these studies really have used mitomycin and epirubicin. There was one study that was published years ago that used gemcitabine, which actually did not show a benefit. So, really in our practice, we really use mitomycin most commonly, but epirubicin is used commonly as well. There's one study from this meta-analysis which suggested that epirubicin may be better than mitomycin. It seems to be a little bit safer as well, as mitomycin can be associated with a kind of a severe inflammatory reaction. So for low-risk patients, again, just a single postoperative installation. The guidelines do not recommend any induction therapy, and there's really no role of the urinary biomarkers in this group. So going back to risk stratification, talk about the intermediate risk. So obviously much higher risk of recurrence, higher rate of progression. And so for intermediate risk patients, really, we do recommend that patients undergo intravesical therapy, and then it's a 6-week induction course. This is a quote directly from the SUO AUA guideline that with intermediate risk patients, there's really very little data evidence to show that BCG is better than mitomycin C. And all things considered, just because there's a higher toxicity profile with BCG, the intravesical chemotherapy might be a better first option for these intermediate risk patients. Consider maintenance therapy up to 1 year for patients who have a complete response. And usually, for at least in my practice, I really only consider maintenance therapy really patients who have high-grade disease. So the multifocal low-grade TAs or larger low-grade lesions, I don't do any maintenance therapy, but it's really the patients who have the high-grade lesions that we're focusing on. And then finally, for high-risk patients, much higher rate of recurrence and progression. And really, one of the things that we have to be better at, which we, and I'm included in that, where the idea that we should re-TUR all these patients. And the reason for this is that, in multiple trials, the original randomized trial in 2006, and then meta-analysis, that repeat TUR, that you have better recurrence-free survival, and potentially even a better progression-free survival in these patients. And the idea is that you are more likely to resect residual disease. And in this meta-analysis, they found up to 40 to 60% of patients had residual disease on repeat TUR. So if you're better, more complete resection, the better your outcomes are, and less recurrences after therapy. So for high-risk patients, really induction course of BCG, as well as maintenance therapy. And the maintenance therapy is based on the original SWOG trial, which goes back to 2000. And it's really changed the practice, in terms of the recommendations from all the guideline committees. In this study, about 600 patients underwent induction BCG. They randomized 384 patients that had a complete response, so had no residual disease at their first 3-month follow-up, and they were randomized to maintenance versus surveillance. So the maintenance schedule in this particular study was 3-week installations at 3 months, 6 months, 12, 18, up to 3 years. And what they found was a significant difference in the recurrence-free survival, 60% versus 41%. And also really the only treatment that has really shown a benefit in terms of progression. So while the absolute benefit wasn't huge, there was a definite benefit in terms of progression, so decreasing the rate of progression in these patients. So high-risk non-muscle bladder cancer, BCG is really superior to intravesical chemotherapy, but really only when including maintenance therapy. So if you just compare 6 weeks induction BCG versus 6 weeks induction of intravesical chemotherapy, the benefit is marginal at best. And, as we all know, there's been a supply chain problem with BCG, and right now, at least there's not enough data to suggest that one strain over the other is necessarily better. So who should undergo cystectomy for non-muscle invasive bladder cancer? And I think the selected patients are really the patients who have the highest risk. So patients who have multifocal high-grade T1, especially associated with CIS, their risk of future progression is upwards of 40 to 50%, and early cystectomy in those patients can potentially lead to better outcomes. Patients who have lymphovascular invasion or variant histologies, those are also the patients that we really need to think about early cystectomy. And then finally, patients who have BCG unresponsive disease. So patients who have had 2 courses of BCG or 2 induction courses and then have high-grade recurrences, especially within the first 12 months. We all are familiar with this graph from this study back in the early 90s from Memorial, which really showed a marked difference in outcomes in patients who went early with cystectomy for non-muscle invasive bladder recurrences versus delayed cystectomy in the group that you wait for muscle invasion. Just one quick slide about the current BCG shortage. So this was some guidance that was provided by the SUO AUA last year when it was in significant shortage, which really still continues today. And in their recommendations, we talked about intermediate risk patients that they should have intravesical chemotherapy. Well, certainly in the era of BCG shortage, we really should be doing chemotherapy in these patients. Prioritizing high risk non-muscle invasive bladder cancer for induction BCG. And in their guidance, in this era, if your supply chain is disrupted and you're really short on BCG availability, you really need to prioritize this BCG for the naive patients and maybe holding maintenance for those patients. So regarding surveillance, just a couple of slides for low risk patients. Their surveillance schedule is not necessarily as intensive as the other intermediate or high risk patients. And really after the first year, you can really slow down their surveillance to annually, and not really any role for cytology in these low risk patients. For intermediate risk and high risk patients, really in the first 2 years, every 3 months to 6 months, in the second 2 years, every 6 to 12 months, and then annually. In the high risk patients, we really stick with every 3 months for the first 2 years and 6 months for the next 2 years. And in both high risk and intermediate risk patients, the guidelines recommend upper tract imaging at 1 to 2 year intervals. So in terms of future questions, obviously we're looking for better urine-based biomarkers, really trying to improve on the specificity and sensitivity, and hopefully being able to stratify patients better. We talked about using molecular and genetic risk stratification to really further divide these patients and maybe identify patients who are at higher risk for progression and maybe early cystectomy in those patients. Can we improve the efficacy of BCG? There are ongoing trials looking at the new checkpoint inhibitors in these patients. Obviously, BCG is an immunotherapy, and so by adding one of the checkpoint inhibitors, can we improve the efficacy for BCG or even salvage some of the patients who fail with BCG? Optimization of intravesical chemotherapy. So this is something that's used outside of the United States quite a bit in terms of electromotive therapy with mitomycin. Right now, unfortunately, not approved in the United States, but if we can further optimize the administration of intravesical therapy, we can perhaps improve the response rates. And then there's still obviously a huge unmet need in the patients who fail BCG in terms of second-line therapy, and lots of trials ongoing right now in this area. All right, so that was a quick overview. We can have a few minutes for questions.
Yeah, so we got a couple questions in the chat. The first one is, in a patient who has a history of high-grade disease with multiple episodes of BCG therapy, if they have low-grade TA-like recurrences, how would you recommend managing them?
Right, so great question, and certainly something that comes up commonly. Honestly, and this is what I tell patients is, don't let low-grade disease get in the way of your treatment and or your lifestyle. Just because Low-grade disease is not dangerous. It's annoying, and there are recurrences, and sometimes require treatments and resections and so forth. But from everything we know, low-grade disease does not lead to progression. So, honestly, I treat each low-grade recurrence as it would as if they were an initial diagnosis. So if they're isolated, small, I don't do any additional treatment. We don't use any BCG for these low-grade patients, so I would not, necessarily recommend doing additional BCG therapy.
Okay. And then we had a couple questions about re-TUR. So somebody was asking about your technique. If when you're taking a look during a re-TURBT and all you see is scar, do you just biopsy the scar, or do you go for the margin? What's generally your technique?
Right. So I think both of those things. I don't just biopsy the scar just because, depending on the time between their initial resection and when you're doing the repeat resection, there can be some underlying invasive disease, and I've seen that. So, I really TUR the scar and then obviously, and then also TUR the margins of that. We don't have blue light cystoscopy, so I don't use that, but the idea is that most of these residual tumors are really either deep to the initial resection or really in the periphery of your resection.
And then somebody asked about, do you generally try for an aggressive deep TUR at the risk of perforation, or on the initial resection, are you going more superficial?
So I'm in the camp of you almost have to see fat to have a good TUR. So I try to do as an aggressive resection the first time around. I'm fairly liberal with leaving catheters in patients after a resection. Obviously that's the risk. If you do a deep resection, you send them home without a catheter, they're going to come back with a perforation. I think with some, judicious use of a postoperative catheter for a few days, I would say that the risk of somebody developing or coming back with a perforation complication is less than 5%, probably even lower than that. So I definitely, feel like we should do as an aggressive a resection up front as we can.
As a follow-up to that, what about if you're thinking about using mitomycin? Does that alter the math at all?
Yeah, I mean, mitomycin, really shows its benefit or in patients with lower risk disease. So, low risk or kind of the low grade intermediate risk patients. And so, to some degree, you have to kind of tailor your methods to what you're looking at. But if someone has a big tumor and you're not sure whether this is going to be a low grade, high grade, or invasive recurrence, I really err on the side of doing a more complete resection up front. If it turns out to be low grade TA and there isn't an invasive component, then so be it. But if you do an aggressive resection, obviously you can't necessarily give mitomycin to all those patients. And in most of my practice, actually, the post-op mitomycin I use is really more in the follow-up. So patients who are having recurrences of low-grade TAs, but unless they come in with a clearly small papillary lesion at the initial diagnosis, those patients might get the immediate mitomycin. But most of the patients who are coming in with larger tumors, I don't do the initial intravesical mitomycin.
Okay. And then somebody asked about if the patient has more than one tumor, even if it looks, very low grade, very small, they're intermediate risk by definition. So in that type of case, would you give intravesical chemo?
Yeah, I mean, it's a good question. I mean, sometimes you really, you'll have maybe one, 1 centimeter or 2 centimeter lesion, and then you see these small papillary changes. I kind of, I guess my own bias kind of stratify those patients based on, how old they are, what kind of urinary symptoms they have at baseline, and really where are the multifocality? Is it really isolated to kind of say one wall of the bladder where it's all just on the, left posterior wall? Or are we really talking about multiple tumors that are more diffusely around the bladder? And really, the value of intravesical therapy in those patients is really to decrease their risk of recurrence. So you're just trying to avoid having them come back to go to the operating room, more than they need to for another biopsy. So, I think I'm sure, they're different from attending to attending in terms of how aggressive they are with the intravesical therapy. I tend to be a little bit less aggressive when it terms for low-grade disease. So most of the patients, I treat more like a low-risk patient than just do, either just surveillance or the immediate post-op mitomycin.
And then somebody asked about how long do you generally maintain your fully catheter in place if you had a particularly aggressive TUR with possibly noted perforation?
So good question. I mean, it depends on, depends on the patient. So, with regards to TUR, how much of a deep resection is it? Is it really broad? Is it, a 3 or 4 centimeter area that you went deep on versus is it just one little isolated area that you went deep on? It's different, I think, in men and women, because obviously their voiding characteristics are different. Obviously, the patient who has a really large prostate who already had, a lot of high pressure voiding, those patients you might wait a little bit longer, 3 or 4 or 5 days with a catheter, versus a patient who has relatively normal voiding or a female where you may just wait a couple of days.
And does that approach alter at all if you're worried about an intraperitoneal perforation?
Yeah, I mean, the intraperitoneal perforations at the time of resection, I think, are relatively infrequent. But yeah, I mean, certainly, in an older patient with a thin bladder wall and so forth, you might just leave a catheter in. I mean, although the upfront pain for the patients of having a catheter in for a little bit longer is it's there, and the patients complain about it. The downside is if you have a perforation, then it really becomes a drawn out longer problem.
Mm-hmm. And I would guess the answer to this question is CIS, but is there anything else that gives you a tip off to start looking for more upper tract type tumors in association with the bladder tumor?
Yeah, I mean, CIS obviously is probably the number one risk factor. But patients who have positive cytologies and not much in the bladder or just some low grade stuff in the bladder, those are the patients. Patients who have a lot of early recurrences. So I've had a few patients who've had kind of quick recurrences of low grade disease, even though they're getting intravesical therapy and so forth. And then those are the patients you might look in the upper tract to see if there's a larger tumor there that's seeding the lower urinary tract.